early to mid-January. So at the bottom, I'd like us to look at the trend of her TFTs, which were done during her initial and subsequent clinic reviews. So we have the first time we saw her in November. That is the first column that you can see there. We have the TSH, T4, and T3. And at this time, her TSH was low, less than 0.008, with an elevated T4 and T3. At this time, remember our diagnosis, or our working diagnosis, was a subacute thyroiditis. Of course, one thing we wanted to rule out at this time was an Hashimoto's thyrotoxicosis, which could also present with this hyperthyroid picture. On the 5th of January, when she came in for her first clinic review post-discharge, we did a repeat TFT, and we saw that at this time, her T3 was actually significantly elevated, 11.42. Her T4 was just about there, and her TSH had remained less than 0.008. So at this time, we were wondering, because of this elevated T3, could this be, maybe Graves' disease? Because you have activation of that thyroid deiodinase that gives you more of an elevated T3 than T4 picture. And at this point, we were really waiting for those antibodies, expecting, your TSH receptor antibody to come back positive. In March of 2024, when she came back again, we did repeat TFTs. And at this time, we noticed her TSH. Remember, this is the time when she actually reported to us that she was pregnant. And we noted that her TSH had dropped further to less than 0.005 with an elevated T4 and an elevated free T3. So now looking back, we wondered, could it have been such that in January when we saw her, she had actually conceived by that time, without our knowledge around that time? And could this be actually a picture of transient hyperthyroidism of pregnancy, especially with the slightly decreased TSH level and with the slightly improved T4, T3 levels, which we actually expect in pregnancy at this time in some patients. So at this time, what we did, because of her symptomatology at this time, she was still complaining of anxiety, of tremors, and that's those typical hyperthyroid symptoms. We thought we should start her on a low-dose PTU at this time at about 50 milligrams OD, in addition to the beta blocker, the propranolol 20 milligrams OD. Now she presented again 2 weeks after that, actually, on the 9th of April, again with repeat TFTs. Her TSH had slightly improved, though we normally don't track that so much in pregnancy because there's a bit of lag in transient hyperthyroidism of pregnancy. But you can see her T4, T3 have improved. And at this time, we could not tell, is it that our PTU is working? Or is it that our T4 and T3 levels are improving as expected in pregnancy? So at this time, actually on the 9th, she had presented with dizziness, and we noted that her blood pressures were actually borderline low, and we actually had to stop her PTU, her propranolol, and her antihypertensives. We followed her up after that, and in May of 2024, that's about a month ago, she actually came back with normal for pregnancy T4, T3s, with still that TSH lagging behind, but that's expected in pregnancy. So we finally got her thyroid antibodies. We were quite surprised that her TSH receptor antibody was actually normal. But her anti-thyroglobulin and anti-thyroid peroxidase were actually quite high. As you can see, her TPO is more than 1,300. So at this time, we were still quite perplexed. Is this it's a painless thyroiditis, but it could still be Hashimoto's versus a subacute thyroiditis, where you may expect your antibodies to still be high in this case. So currently, we stopped her PTU and all her thyroid medications. Her BP and pulse are stable. She continues to be followed up by an endocrinologist and an obstetrician, and her pregnancy is going on well, and she actually remains asymptomatic during this time. So the plan for her was, we still have a diagnostic conundrum for her. We need to track her TFTs during her, intrapartum period and during her pregnancy. We need to decide whether, is this a lady where we'll, end up doing maybe a radioactive scan for her to hopefully differentiate, is this purely thyroiditis versus Graves versus Hashimoto's, or we may need to consider technetium scan for her. Also, we need to repeat her antibodies post-pregnancy to look at the trend. If it's Hashimoto's, they will be persistently high, even if she has normal TFTs. If it's, thyroiditis, subacute thyroiditis, they should essentially have a decline trend. So why this case? You can see it was actually quite a diagnostic dilemma for us. You can see our train of thought from, is it just an infectious thyroiditis or post-infectious thyroiditis, to autoimmune, to possibly some superimposed component of gestational transient thyrotoxicosis. Was the use of PTU in this case justified in this patient? And what are thyroid hormone targets in pregnancy? Should we follow the TSH in pregnancy? So we'll just look at this slide. Essentially enunciates the pattern of thyroiditis generally, from a thyrotoxicosis phase to a hypothyroid phase to when the patient initially becomes euthyroid. You can see how if a patient has background thyroiditis and presents in pregnancy, especially in the thyrotoxicosis phase, how much of a conundrum it can cause, because you already have that low TSH or primary hyperthyroidism picture, which may be exacerbated in early pregnancy. So it really presents a case for us which may be challenging for us as physicians and endocrinologists. So the thyroid metabolism in pregnancy is there's a huge change, essentially. You have increase in your T4, T3, and a reduction in your TSH. And this is essentially because of increased thyroid binding globulin in circulation, which is due to several reasons. You have your kidneys, whereby you have increased renal blood flow, which is seen in pregnancy. You increased GFR. You have iodine being secreted in urine, and additionally, you have increased tubular reabsorption of iodine, which essentially causes iodine deficiency and triggers the thyroid gland to synthesize and release more hormones. In the liver, you have estrogen, which is released which is formed in pregnancy, which leads to production of increased TBG, and this increases the synthesis and the half-life of this protein, which leads to increased serum levels of T4 and T3, and it's normally your total T4 and T3 which is elevated, but your free T4, T3 remains normal. In the thyroid gland, because of the iodine deficiency, you have iodine trapping by the thyroid gland, which leads to increased uptake of iodine from blood, and this leads to increased synthesis of your thyroid hormones T4 and T3. So I think Dr. Saira will now take over. She will present on the approach to management of these patients, and then afterwards we'll have discussion and questions. Thank you.
Yes, thank you very much, Sandra, for discussing this, or rather presenting the case. Maybe as we put up the presentation, you can see that thyrotoxicosis in pregnancy is usually not a very simple condition to always look at. So this patient, by the time they were referred to me, actually the patient was nicely and appropriately, as you can see, being managed for thyroiditis based on the clinical presentation in November. And by the time they were sent to me was somewhere in March, when they'd already conceived. And now what was noted is that, you see, in subacute thyroiditis, you expect the thyroid levels to improve by this time. But what we noticed is that the thyroid levels continue to actually go higher. And especially after she conceived, the whole question was now what is happening, you know? Is this just thyroiditis? Is there an element of gestational transient thyrotoxicosis? Is there an element of Graves? So all those questions came in, and that's why sometimes it's not a straightforward diagnosis. So by the time I was seeing the patient was already on a low dose of PTU, but also had come with thyroid antibody levels which were elevated, as you can see, the TPO antibodies, but they had not yet done the TSH receptor antibodies. So he said because of her symptoms and the blood, the pulses were actually on the lower side, so we couldn't go much higher on the propranolol. So we decided to continue her on the low dose PTU as we followed up with the TSH receptor antibodies, which when we found them to be negative, we actually held the PTU and we then continued to follow her up, and you can see now the levels are basically normal. So let's go through then this presentation, and first I'll take us through the lows rather than the highs so that you understand the highs as we further discuss the case. So it's a really long presentation. All of you are geared up. That's why we made you have tea right before the talk. But I can assure you it's a topic that is I think everyone in primary care, tertiary care, you do come across patients you are managing, you suddenly find them to be pregnant and you're dealing with thyroid, hyper, and you need to take care of them alongside your gynecology colleagues, right? So first of all, it's always very important to understand what is the physiology of the thyroid. Sandra has told us a little bit about it, and yesterday, I'm so happy, we already had a talk on the thyroid and babies, so I'm not going to go into the detail of the effect on the babies so much, but just we do understand the normal physiology of the thyroid cycle, right, at the whole pituitary, hypothalamic pituitary thyroid axis. So what happens is the hypothalamus produces your TRH, thyrotropin releasing hormone. Thyrotropin simply means TSH. And then that goes to the pituitary, which actually then increases your production of thyroid stimulating hormone, TSH. TSH goes on the thyroid gland, works on your TSH receptors and increases your production of T3 and T4. And the T3 and T4 then they are bound to thyroid binding globulin in the circulation majorly, and a small proportion, less than 1%, is available in the free form for action on the tissues that they work on. Is that clear for all? Great. So these hormones then actually go back to the brain, to the hypothalamus and pituitary to give a negative feedback, and that's how the cycle is regulated. In pregnancy, what's happening? You actually have increased estrogen production from the placenta. So estrogen causes the liver to produce increased thyroid binding globulin, which what will it do? It's going to bind all the thyroid hormone, so cause less free hormone available in the circulation. That's one effect that happens. Secondly, there is HCG production, yeah? So human chorionic gonadotropin. And what's interesting is the alpha unit of the HCG is very similar to the alpha subunit of the TSH, and so it can work directly on those TSH receptors to cause increased production of your T4 and T3, and this will then give a negative feedback and cause reduction in your TSH in the pregnancy, early pregnancy especially. And then the placenta also produces deiodinase enzymes, especially the T3, which increases your conversion of T4 to reverse T3. So there is all these changes happening to the thyroid hormones, and this is just a very interesting way or a summarized way of presenting everything in the physiology that takes place in a normal pregnancy. So as you can see, if you look at the different graphs, before we go there, just go to the lower part of this graph, and you can see that basically the baby, the fetus starts producing thyroid hormones from about 18 to 20 weeks of gestation. Till then they depend on maternal thyroid, and thyroid hormone is required for neurodevelopment, as we learnt in detail yesterday. So and even during that time, the whole of pregnancy, there's still some dependence on the maternal thyroid hormone. So there's requirement of thyroxine or rather thyroid hormones increasing as the pregnancy proceeds. And remember that the hormone that moves across the placenta more is T4. So that is why we measure the T4 levels and we want it in the upper half of normal, or even sometimes above normal in hyperthyroid cases during pregnancy. There is increased clearance of iodine, as Sandra has already mentioned, and there is also the degradation, as we mentioned. So what happens? As you look at the week 10, look at the point of week 10, your HCG is increasing, that's the gray line. You can see that the HCG is significantly going higher, and sometimes it can go excessively high to cause hyperemesis gravidarum, which could be a normal phenomenon. But in that case, then you will get hyperthyroidism or rather thyrotoxic picture if you look at your thyroid function test, and that is why you get this gestational transient thyrotoxicosis. At the same time that the HCG is going up, like I mentioned to you, there is also an increase in T4. The red line actually is the free T4. Now your thyroid binding globulin is also increasing. Look at the green lines, the dark and the light green. As your thyroid binding globulin is increasing, your total T4 is increasing. Remember, the thyroid binding globulin is attaching your T4 to it. So the total T4 will increase and then plateau throughout pregnancy as the thyroid binding globulin increases. So then the total and the free T4 measurement, that's where it comes in during pregnancy. You don't normally see us asking for total T4, but in pregnancy sometimes that can be useful. When you look at your TSH, in the early pregnancy there's a drop in TSH which then stabilizes, but look at the baseline. When you look at conception and look at the TSH later, you'll still see that there is a overall reduction of the TSH during pregnancy, and that's why the cutoff values. So this is graphically just, tabulated, showing what happens then to the different thyroid levels. If you look at your TSH, it will be reduced in pregnancy. The free T4 may not have a change, okay, because there is the adjustments that happen, but the total T4 and total T3 will be high, and that's in comparison to what happens in high thyroid states. This is primary hyperthyroid or primary hypothyroid, as we shall discuss a little bit in detail. So then the question is then what should be your TSH in pregnancy, right? And that's the question all of us always have, is what should be your specific TSH reference. So there should be a trimester specific reference range based on the population. So the TSH reference range, for example, we have seen in studies from the States and the European countries is not the same as the reference range from Asian countries. We don't unfortunately have reference ranges as such from the African continent, but then if generally the reference values that you'd use, just to remember, in non-pregnant females is up to 4.5, right? But in the first trimester, it's much lower, 0.1. Just remember 0.1, 0.2, 0.3 as the lower reference, and then 2.5, 3.3 as the upper reference in your trimesters. Okay, so then let's move on quickly to hypothyroidism in pregnancy. We know this is, I'm particularly focusing on primary hypothyroidism first, is where you have an elevated TSH and a reduced T4 concentration, with both concentrations looked at in the pregnancy reference ranges, not what you get from the lab generally. And pregnancy reference, your T4 you want in the upper half of normal preferably. The causes of hypothyroidism in pregnancy are more or less similar to what it is in the general population, where you have adequate iodine, like in our setup we have got luckily iodized salt. Our prevalent cause is not iodine deficiency but rather Hashimoto's or iatrogenic, like in cases of post-radioactive iodine or post-surgical treatment. There could be other causes, as you see. Remember to always ask for drugs. Lithium, amiodarone and antithyroid agents can actually cause hypothyroidism. There is the secondary and the tertiary causes which are much more rare than primary causes. So this is exactly what I've talked about. You can see that the antibody levels, anti-TP or anti-thyroglobulin, are present in up to 2 to 17% of unselected pregnant women as well. How about the signs and symptoms? I think everybody in this room, who doesn't know how a patient with hypothyroid can present? I believe we all know that, right? So these are the whole conundrum of signs and symptoms that patients with hypothyroidism can come with. However, in pregnancy, this is the problem. symptoms are masked by the hypermetabolic state of pregnancy. Pregnancy is hypermetabolic, right? And so what happens is only about 20 to 30% of your patients present with overt hypothyroid symptoms. So you have to look for it in these patients and have a keen eye of suspicion when you're looking at it, okay? So there's the other question of antibodies, thyroid antibodies. So if a patient has thyroid antibodies before even they conceive, does it increase their risk of pregnancy losses? And that's a question that has been asked several times. There are big studies and trials on this, and it has to be under certain circumstances, as you see. So it increases in some cases your risk of even pregnancy losses, but what is interesting is they do not cause thyroid dysfunction in the baby, okay? So the recommendation is that your euthyroid women who have TPO or TG antibody positivity, you should measure the serum TSH concentrations. Now in our setup, we don't routinely do antibodies, but the patients who have been done antibodies for any reason in the past, if they were positive, then at diagnosis or at the confirmation of pregnancy, you need to do your TSH levels, okay? And then you see what the TSH is like. If the TSH is normal, you can repeat it every 4 weekly till about mid-pregnancy. Euthyroid and positive antibodies. Now your antibodies are positive and you have now got TSH which is in the normal range. Is there a role for treatment? So basically you don't need to treat them if their TSH is below 2.5. But if there was a previous pregnancy loss, then you can actually consider treatment with the low dose thyroxine, even if your TSH is in below 2.5 and your patient has got thyroid peroxidase antibodies positive. So this is interesting. Yeah, so how about screening? Should we screen all our patients? Should we do universal screening or should we go for targeted screening? So currently as per the ATA guidelines, they do not recommend universal screening. They look actually at a targeted screening approach. However, what we know is that there are studies now coming up showing that a universal screening approach may be appropriate, okay? But in women who are planning assisted reproductive technologies, that's why I was asking Dr. Muragi about this in the morning. If you're planning ART, or if you're known to have TPO antibody positivity, you need to screen them for hypothyroidism, okay? So they talk about taking a history. So if a patient comes to you, they're pregnant, make sure you ask every woman, pregnant woman who comes the first visit about these symptoms or this particular clinical information. Do they have a history of thyroid disease? Do they use thyroid hormones? Are they on antithyroid medication? Do they have a family history of autoimmunity? And so the recommendation for screening is all patients seeking pregnancy should undergo clinical evaluation. If any one of these risk factors is identified, you need to check for your serum TSH. So either they've had a history of hypo or hyperthyroidism or symptoms in keeping with any of these thyroid diseases, known to have thyroperoxidase antibody positivity, or if they have a goiter, hair or neck radiation before surgery, age more than 30, which is nowadays quite a lot of our pregnant women. So we need to be ideally screening. I think quite a lot of our women will fall in this category. If they have type 1 diabetes or any other autoimmune diseases, history of pregnancy loss, preterm delivery or infertility, multiple prior pregnancies, that's more than 2, and a family history of autoimmune disease or thyroid dysfunction, morbid obesity, okay, and use of the drugs that we mentioned, or residing in an area of moderate or severe iodine deficiency, okay. So there's studies now coming up showing that there's role of universal screening, and I think the guidelines will take up. Some of the guidelines across the world have taken this up. In resource adequate settings, I would suggest if you can, please do a TSH in your pregnant women in the first trimester, especially if you look at the conditions that are there. But if you can't, at least look for the risk factors and do a targeted screening. So how do you treat then? So if your TSH is elevated, you need to check at least for a free T4 level. They're still recommending free T4, okay, especially in early pregnancy. Later pregnancy, total T4 can be useful as well. And treatment of hypothyroidism is recommended overt. If you have got a low T4 and you have got a high TSH, then of course you need to treat. There's no question about that, right? And the treatment is with oral thyroxine. No other drug is recommended, like desiccated thyroid or T3. So similar to the general population, you target TSH in the lower half of the trimester specific reference range and at least target to less than 2.5. Okay, so there are some women who you need to actually be careful and probably need to significantly increase the dose of thyroxine in pregnancy, like those who went through radioactive iodine or surgery for their treatment of hyperthyroidism, for example, in the past. You also have to look at your preconception TSH values to adjust the doses of your treatment. Now, patients who are on levothyroxine, what should you do? So if your patient is in a euthyroid state before pregnancy, you need to increase your dose. This is very important, please. We forget to do that. So you need to increase your dose of levothyroxine. So let us say a patient was taking 100 micrograms once a day. How will you increase your dose? You are going to increase by 2 doses in a week. So for example, if they were taking 100 mics Monday to Sunday, you'll give 100 Monday, Tuesday, Wednesday, Thursday, Friday, 200 Saturday, 200 Sunday, or you can decide to distribute that across the week. But remember, it's equivalent to 2 dose increase. Then you leave it at that dose for a month, repeat your thyroid levels, and you see where you stand, and then increase further. So it is based on that kind of simplified method of increments, okay? And of course, those who are planning pregnancy and they known to have hypothyroidism, make sure that their thyroid level is under control before they conceive. Now, there's this huge question of what do you do with subclinical hypothyroidism in pregnancy, which is a bigger issue, I believe, than overt hypothyroidism. So pregnant women with TSH more than 2.5, you should do your TPO antibody status, okay? Where you, I mean, it should be, hopefully at least once you can afford to do it, you do it. LT4 is recommended if you have TPO antibody positive and TSH is greater than the pregnancy-specific reference range. Now, this is an interesting concept. So, it's not if it is just more than 2.5. So, more than 2.5, but pregnancy-specific reference range, they talk of minus 0.5 below the upper reference range. So, about 4. So, if you have got your TSH of above 4 and antibody are positive, then you definitely need to treat. If antibodies are negative, then your TSH, if it is more than 10, you will treat, okay? So that means any patient who comes with normal T4, normal T3, TSH above 10, you are definitely going to treat for subclinical hypothyroidism, okay? And it may be considered, if you have got your antibody positive, TSH is more than 2.5, but below the pregnancy-specific reference or below 4. So let's say 2.5 to 4 in certain group of patients, especially if they've had pregnancy losses, okay? So levothyroxine is not recommended for TPO antibody negative and normal TSH. I think that's pretty understood. So this is just a summary of what we have said with subclinical hypothyroidism. So if you have your high-risk woman, patient, you check TSH, and if they are low, the TSH is above 2.5, you do your antibodies. And this is when your T4 is normal. If your TSH is low, of course, you'll treat as thyrotoxicosis. If it's high, more than 10, you have to treat. If it is between 2.5 to 10, that's where the problem comes. You do your antibodies. If your positive antibodies and your reference is between 2.5 and the upper limit of reference, that's up to 4, then you consider treatment. If it is up to 10, then you definitely treat. And the other part, as you can see. So hyperthyroidism or thyrotoxicosis in pregnancy. Hyperthyroidism affects about the numbers that you see, 0.1 to 0.4% of the pregnancies, and it is marked by increased circulating thyroid hormone levels. At this point, I'll just tell you the difference between hyperthyroidism and thyrotoxicosis. They are not the same thing. Thyrotoxicosis means elevated thyroid levels for any reason. Hyperthyroidism is your thyroid gland is the one that is producing the excessive thyroid hormone to cause excessive thyroid in the circulation. And so there are etiologies then based on that. So causes of thyrotoxicosis with hyperthyroidism is things like Graves' disease, okay, autoimmune thyroiditis, TSH secreting pituitary adenomas, trophoblastic tumors, as we said, like Hcg will make your thyroid produce extra thyroid hormone, or thyroid adenomas and multinodular goiters. Whereas the conditions where you just have thyrotoxicosis like in our patient, but not extra production, is like thyroiditis. All the thyroiditis otherwise that you know fall in this category. That's the subacute decovens thyroiditis, drug-induced thyroiditis, you know, acute suppurative and all the other causes as you can see there, including postpartum thyroiditis. And the symptoms of hyperthyroidism, again, we all know, just before a presentation, this is what we get, even before an exam, right? So this is classical of symptoms of hyperthyroidism, especially with Graves, you even get the bulging eyes and all. These are just some of the complications of hyperthyroidism. So specific to pregnancy now, etiologies of thyroid hyper or thyrotoxic states, right? So Graves' disease is associated with increased pregnancy losses. If it is not handled well, you can see all the complications that are associated. We know the pathophysiology is related to TSH receptor antibody production, and this leads to all these specific features other than just thyrotoxicosis, which is Graves' ophthalmopathy, Graves' dermopathy, Graves' acropathy in your nails. So these are the things that you'd look for with Graves' disease. Trophoblastic disease, I think we mentioned about it, where there is excessive production of HCG, which can then lead to your increased thyroid production as mentioned. This is what we have already talked about. Gestational transient thyrotoxicosis can occur when HCG levels are very high, but it's normal in the pregnancy, and it could be considered as a normal phenomenon, and usually doesn't need treatment. But in some cases you need to give antithyroid in worst case situations, but not usually recommended, okay? So it differs from Graves' disease. How? If a patient comes, there's no history suggestive, there are no ophthalmopathic signs, and when you do your antibodies like we did in our patient, it was negative, yeah? So this again is just to remind us the changes that happen in early pregnancy, and this is where your gestational thyrotoxicosis of pregnancy could fall in. How about toxic adenomas? They can also be there. You need to look for them. Remember that the goiters can increase during pregnancy because again of the HCG effect, and after delivery they usually stabilize. So that's something to look for. And thyroiditis we have already again talked about. Dequavines is painful thyroiditis. Important concept to remember is this postpartum thyroiditis, which happens after delivery. And basically it's a little bit different from what Sandra presented with the subacute thyroiditis. In subacute you get high thyroid, low, and then normalizing thyroid. In postpartum you actually get high thyroid levels, you get normal levels, and then you tend to get a dip in your thyroid level later, which then stabilizes, okay? So how will you evaluate? You're going to, actually, if your peak HCG should be between 7 and 11 weeks of gestation, right? So if your serum TSH is less than 0.1, what you're going to do is you're going to actually check for your T3 and the T4 levels, okay? And overt hyperthyroidism is when you have a low TSH, but your T3, T4 are high. So you'll try to then identify your cause, check your history with all the features that we have talked about, and if no other causes, I mean if you are suspecting Graves, you'll check your TSH receptor antibodies. If they are nodules, you do your thyroid ultrasound. And total T3 if you suspect T3 thyrotoxicosis. In pregnancy, remember you cannot do technetium uptake or radioactive iodine uptake scanning, so please take care of that. So treatment depends on the severity of your symptoms. This is gestational thyrotoxicosis. And if you have hyperemesis, you'll give, controlled vomiting, dehydration. If you have severe hyperemesis gravidarum, then the patients may even need admissions. Antithyroid drugs in this case are not always indicated because the serum T4 returns to normal. So if our patient only had GTT, we would not actually be right if we were giving them PTU, right? So that's what you have to be careful, beta blockers to be considered. How about Graves' disease? Ideally, if your patient is known to have Graves' disease, control their thyroid levels before pregnancy. Whether you use medical therapy, you use radioactive iodine, remember, again after radioactive iodine, at least 6 months your patients cannot conceive. Or you use surgery, depending on your discussion with the patient. But if your patient comes in during pregnancy, then those are the things also that you have to discuss with them. You'll not do surgery. I know my time is, I'd ask for 5 minutes extra. Is it okay if I take 2-3 minutes? I'm actually almost done. So these are the different options that you have for your management of thyroid disease. Generally, this is before or after pregnancy. So Rosie has given me 5 minutes. Who can reject that? Okay, it's a long topic and I think extremely important as well. So yeah, but basically before pregnancy, we try to get our thyroid levels under control. Drugs will help you. You can see the advantages and disadvantages. The advantage with drugs is that they'll quickly help to control the levels. However, one thing you have to know is that about 50 to 60% of the patients could go into even remission with drugs, and then there's a chance of relapse later, but they could be a good option. And in the beginning, anyway, drugs are the best option because you have to bring your levels down, whether you're considering radioactive iodine or you're considering surgery. With radioactive iodine, it's a very easy way of administering, but it has to be done, like I said, before pregnancy. And the only thing with that is with radioactive iodine, it can actually lead your levels to go very low. If your patient has Graves' ophthalmopathy, try to be cautious when you are considering radioactive iodine, and the patient may need to be on thyroxine for life. Thyroidectomy, of course, we all know it's definitive treatment, therapy. So women taking methimazole, carbimazole, or PTU should be instructed to confirm potential pregnancy as soon as possible. Ideally, if your patient wants to be, or rather, if your patient is diagnosed with Graves' disease, this is one area I think we all lack in significantly, is pre-conception counseling. Not only with Graves' disease, but with a lot of conditions, like even with diabetes, you need to tell them you do not want to conceive, you preferably be on contraception, like was advised in our patient correctly, but she still went and conceived, right? Even before the levels were stabilized. But so you have to tell the patient to stabilize the levels, and then you help them to plan pregnancy. Okay, and if your patient is newly diagnosed with and confirmed to have pregnant, this is quite interesting, and we have seen it in practice. Yeah, your patient had Graves' disease, they've come to you, now they are pregnant. You check their thyroid levels, they are good, they are within the euthyroid state. If they were taking a low dose of carbimazole or PTU, you can actually stop it. How many of you knew that? How many of you do that? But I've seen it, and we have done it in our patients. There's one of my patients who I had to actually give a thyroxine at some point after Graves' disease because the levels drop very low if you continue giving antithyroid drugs, yeah? Because you do want the levels to be a little bit higher in pregnancy, as we said, because of the child's requirement. But of course, before stopping, you need to consider all these actions. What are their TREB levels? What are their recent thyroid levels? And you need to be able to monitor their functions at least every 1 to 2 weekly if you are stopping the antithyroid drugs. Okay? So in pregnant women at a high risk of developing thyroid toxicosis, of course, you will not withdraw the drugs, as we said, yeah? And this is what we were saying, factors predicting high clinical risk is if they need higher doses than the 5 to 10. PTU is recommended through 16 weeks. After 16 weeks, you can actually switch back the patient to carbimazole. And why are we opting for carbimazole or methimazole compared to PTU? Anybody? Anyone can say it? Excellent, that's one of the reasons. It helps with reducing your transfer of the TREB, but also because actually carbimazole is less hepatotoxic. Initially, PTU is, why we are giving is because less of PTU is transferred across the placenta, but it is not a zero risk. There is still transfer happening and it still can be teratogenic, but it is less than carbimazole. That's why in the early part where you're having embryogenesis happening and your organs are forming, you do not want to give an agent that can increase the risk of embryonic issues, right? So up to 16 weeks you can give PTU, then you can switch the patient to carbimazole or methimazole, and this is a nice way of showing in the early trimester you can actually do PTU and then go to methimazole, and you'll need reducing doses as the pregnancy goes on. So you'll monitor your thyroid function test at least every 4 weeks, and basically try to keep it in the upper reference of normal, okay? Thyroidectomy in pregnancy, you want to avoid it, but if you must, it should be done in the second trimester of pregnancy. And nodules, just one slide on that, is that how do you treat nodules in pregnancy? With your antithyroid drugs, but there are other modalities coming up. I had a patient recently, very interesting story, is a patient who came in with a toxic nodule. She did not want surgery, she did not want antithyroid drugs. We were preparing her for radiofrequency ablation, counseled her on not getting pregnant. But of course, this is Kenya. And she was not even Kenyan, but she conceived. So she conceived, and then there was trouble. We actually had serious issues managing. She had just isolated T3 thyrotoxicosis because the nodule was producing T3. So it was such a challenge to manage her levels. You give her thyroxine, carbimazole, the levels drop too low. You give her, you can't give a thyroxine. We ended up doing a very unique method. I don't even want to talk about it. It's not approved probably, but eventually she got radiofrequency ablation after delivery, and she's doing very well. So then our case, going back to it with the question Sandra raised, is initial thought was acute or subacute thyroiditis, right? But our antibodies were positive. So we're thinking of Hashimoto's versus Graves at this point. Then the issue of pregnancy came in. So there was the element of gestational transient thyrotoxicosis here. So we were probably dealing with two conditions. You can have that, right? And then it was not just Graves' disease, definitely, yeah? Was it justified? How many of you say we were justified to put this patient on PTU? Low dose PTU. Yes, so it's not a clear yes or no, right? And thyroid hormone targets, as we said in this case. And then, yeah, TSH, don't keep measuring if the TSH is low. Okay, because TSH will be low for long, especially if they have had Graves' disease uncontrolled in the early pregnancy. So to conclude, understanding the thyroid physiology during pregnancy is key in recognizing these thyroid disorders. Hypothyroidism and subclinical hypo are common, and they do have significant consequences. Screening for thyroid disease is actually controversial, but should be considered, at least those at high risk, okay? Management of hyperthyroidism, look at trimester-specific references. Thyroid nodule monitoring should also be considered. So there are many highs and lows in pregnancy, and this was just one of them. Thank you.
Thank you, Dr. Saira. Excellent, and Dr. Sandra, excellent presentations. Sandra, do you want to come up? I will take a few questions. Rosie?
Thanks for that excellent presentation, as always, Saira. But what I'm wondering is, you've talked about these antibodies, especially in pregnancy, but in a low resource setup, what are we going to do? Even getting that TSH done, honestly, is going to cost. So what I'm wondering is, in as much as, okay, we'll screen the patient, and we find she's got a TSH that's like 5 or 6, and T4 is normal. And the question is, do you treat or do you not? And we are not able to do her TPO antibodies, because you say, if it is positive, then treat. If it is negative, then don't. But I'm wondering about a lady in Garissa or Embu who cannot afford to do these TPO antibodies, then what would you do?
And that's very true. And we do have women delivering all over the place, even though they have these changes, right? Honestly, I see patients who come to me at 15, 16 weeks, they've been on carbimazole, 20 milligrams TDS 3 times a day, 60 milligrams of carbimazole, and they have bouncing babies, right? But the risk is there. Of course, we know the risks are there, and that's what we want to try and mitigate. But I mean, we have to live within our means. I totally agree with you. But I think these are some of the, like when we have these presentations and all, it also opens up our minds to see what we can do at our different levels to help to improve, like at least get a TPO antibody availability in some of the, at least the tertiary level facilities within the regions. But I totally agree, this can be quite challenging, and you'd rather err in a subclinical hypothyroidism, especially in early trimester, you'd rather err on the side of overtreating, I think, rather than undertreating, because the risks of hypothyroidism on the baby's neurological development are significant. So I would rather give a low dose of thyroxine and try and be able to monitor at least the TSH reference levels.
Agreed.
Sorry,
So
can
a
I just
question.
make a final comment?
Yes.
Kdsg alongside Merck is having a program which we're going to be launching soon with regards to screening, where they're called Lancet. Sabalancet, sorry. Sabalancet are going to actually do the test, the screening test of the TSH at half the price. But what we are recommending, though, is please don't send everyone in the population. You know the likely, the symptom presentation for both high and low. Those are the people you'll actually send to Lancet, and they'll be able to do the screening test. And this is actually going to help us in terms of the statistics, the numbers. We keep saying we don't have data, but we are hoping to get data from that to see, as we screen certain populations, the pregnant ones, the ones with symptoms specifically, we can be able to have an idea of our population prevalence.
Thank you. That deserves a round of applause. Definitely. I think there's a very interesting group that I also happen to, some of them are my patients as well, but this Thyroid Disease Awareness Kenya. And they're doing a great, great job. So if they do come and approach you, they're really willing to work with us to create awareness on thyroid diseases. How many of us have seen patients when we are seeing them, their eyes are bulging out, you know, they have a lot of stigma attached, they were labeled to have witchcraft, drug addicts, some of them, and they come to us and, you know, it's so late, but at least we can, then we start doing thyroidectomies and all. But then, so just to create awareness out there, I think is very important so that people start using even these tests and screening more frequently. That's a support group, Thyroid Disease Awareness Kenya. Just go online and you can actually search for them. They were supposed to be here today. Unfortunately, they couldn't make it. They wanted to come here at their own cost and be able to create awareness with us. So that's one of the ways, one of the platforms that we can also use to create awareness.
Last question here.
All right, I think Dr. Rosie actually partially answered my question, but here's the question. Is it possible to create, you know, like a chart where would do targeted screening for these particular mothers in the case of a low resource setting, especially where we've got ASAL counties and having mothers who are coming in pregnant past 30 years, because now 30 plus is of course a risk factor.
That is so excellent. If you can, you see, like the way even glucose testing, like the 75 grams OGTT initially was just recommended to be done opportunistically, right? In high-risk women and all at 24 to 28 weeks. Now it's a universal recommendation actually. But in our low resource settings even there's still a challenge. But like if in the antenatal chart, you know, the antenatal book that the government releases, if we could have a screen just for thyroid disease, that's something to think about. Anyone can comment on that maybe? From Kdsg? Or anyone who wants to talk on that?
I think that is an excellent, it should be made the same way we do VDRL, HIV, it probably should include a TSH in there with our gynecology team. So sorry, as Hilda, the last question. It's interesting, Dr. Sarah, that you'd present this case because majority of us, especially in the peripheries, will just do a TSH for pregnant mothers. And for this lady, I mean, the TSH all through was less than 0.1. And so we just pump this patient with PTU, you know.
Exactly, yeah.
I mean, and I think that's the importance of let's spread awareness that it's not only TSH in pregnancy, we need to look at T3s and T4s.
By the way, just one information on that is the TSH is very good for monitoring hypothyroidism and only primary hypothyroidism. Yeah. Again, not secondary, not pituitary related. So your TSH is a good marker where you're only checking for progress to treatment in hypothyroidism. In hyperthyroidism or in thyrotoxicosis, TSH alone is not a good measure of monitoring follow-up. T4 would be a better, and that is free T4 would be a better way of assessing your progress to treatment.
Thanks. Hilda?
Mine first have been asked by the Vice President of Kdsg to say that Kdsg and COGS will work and will collaborate to see whether we can get that TSH part in the final maternity health booklet. So I think that's a good point, Rosie. Now, what I wanted to say is I've worked in low resource settings a number of times. One of the things that is very important is communication, just like with diabetes. When you tell this mother how important this test is, when it comes to now the antibodies, they usually, they understand. And if you give them time, they can save up even if it's 500 shillings per month. At the end of the year, I've found patients who come and tell me, daktari, nimepata sasa pesa, tufanye test. So let's not just say, oh, they don't have money and then forget about it. Let's keep on remembering that, hey, we still have to do the test at some point. Even if it's not in this pregnancy, after the pregnancy, let's keep on reminding them so that at least let's get that test for those who we can. Then the other thing I wanted to say is, in especially the private, public sector, thyroid disease has been just taken up by the surgeons. So you just find so many thyroid cases in the surgical ward, and there's no proper collaboration, there's no proper follow-up. Everybody gets a thyroidectomy. As long as you have a TSH that is just abnormal, it's gone. So I think we need to, it's true. I've seen it so many times. So we really need to create collaboration with the surgeons so that we now come up with a proper guideline. When does the surgeon take over? When do we come in? So that it guides us in the country, so that we avoid the chua. Thank you.
Thank you, Hilda, and we're in agreement. A round of applause for our presenters. Let's take a photo. Eric. Yes. Thank you very much. On to an exciting segment. I'm handing over to Eric.
So now I think now we are in our last session today. Quiz time. So this now is going to be interesting. We'll look at syndromic endocrinology, and Dr. Dara Patel, is she around? So I'm going to introduce her. So she's a consultant physician, endocrinologist, who is also in private practice. And we're going to go through a couple of cases and try to jog our memories and try to see whether we can be able to pick up these clinical cases in endocrinology. And then from there, we'll have a Q&A session and then wrap it up. So let's all put our thinking caps on, and let's give a big round of applause to Dr. Dara as she kicks us off for our final session. Thank you.
Thank you, Dr. Eric, for that kind introduction. And thank you to all the speakers and Kdsg team and everybody who's here to still be here when it's time for lunch. It's time to rush home, catching our flights. So we'll start with a bit of introduction. I'll try to not ask everything and give a little bit from my side so that I don't sound like I'm very mean and taking away from you. Can you have our slides, please? It had been projected, I don't know. There was a QR code that was projected. I would like us to log into that and Zippy, are we able to project the QR code again just for those who missed it? So once the code is projected, just open the site and you'll get a link to Zoom and you'll be able to answer the questions that come ahead. Yes, you'll register on for those of us who are on the Kdsg WhatsApp group, there is also a link on the same. You can still use that link to register and log in to Zoom. Are we ready? Not yet? Okay. So just as we register, I just wanted to make a small comment, sorry, on the previous presentation. I think we mentioned we have these pregnant women or patients who cannot get surgery for those toxic thyroid nodules. They are not ready for radioiodine radioiodine ablation for whatever reason. There are new treatment modes coming up in certain parts of the world, not costing a lot. Maybe we should engage our interventional radiologists as well, where they do this embolization, thyroid artery embolization, to slowly shrink those nodules. And I've seen it personally work very well for some elderly patients and also for a pregnant lady that I saw in India. And it's now coming up. So maybe we should also be working closely with our interventional radiologists and not just the surgeons. Are we are okay? So can we start? Yeah. So I'll just project something on the endocrine system. We all know what the endocrine system comprises of. We'll all know what most of those hormones do, but there are a few of us, maybe we've never really given a thought to some of the organs, such as the thymus. Did we know that the thymus is also an endocrine organ? Very good. Of course, the endocrinologists will know that. Yeah. So I don't really have any major disclaimer to make. I'll just thank Kdsg for the opportunity. Can you have the next slide? So that's just the outline. It's kind of a leakage to the quiz as well. So what's a syndrome? Basically a collection of signs and symptoms that tend to occur together in any specific disease or disorder state. And it could also be several diseases occurring in that one particular person. So that's just the basic of the endocrine system. We can see starting from the brain all the way down, and the endocrine system does keep us alive. So we find that life-threatening situations do occur with endocrine disability. So it's not that we are not important in patient management. Next. So that's just some of the hormones being produced. So we'll have the next slide, which is now our first question. Some of the people on the front rows must be very familiar with this slide. It's taken from our Kdsg website, and that's the first question. So what is the most likely diagnosis, or what are the likely diagnoses for this patient who's having frequent urination, dry skin, blurred vision, feeling drowsy, having excessive hunger, and seems to be drinking a lot of water? For some, it's you're not able to answer. Anybody who's been able to answer it? Some people are able to answer, others, I don't know what's happening. It's not appearing? It's, sorry, yeah, I think we'll just do an interactive session to keep time. So what do we think the answer is? What do we think the answer could be? So we have A, hypoglycemia, B, diabetes mellitus, C, diabetes insipidus, D, hypercalcemia, and E, all of the above. Who thinks it's all of the above? Who thinks it's diabetes mellitus? Very good. I actually thought most of us will say all of the above, but I think we are much smarter than. Next. So the clue was in the hunger. If you have DI or hypercalcemia, you will not be hungry, but in diabetes mellitus, you will be hungry. Next, so this is where you have abdominal pain, vomiting, difficulty in breathing, in addition to what we've seen in the first question. And this when we must check for ketones in serum, and if we don't have access to serum ketones, we can do a simple urinalysis, even bedside, to confirm if there is any ketones. Again, not just waiting for someone to have difficulty in breathing and vomiting. Anybody who presents with hyperglycemia for the first time or any type 1 diabetic, or those diabetics who have a history of ketoacidosis and have now come with hyperglycemia, we must check for ketosis. Next slide. So again, similar picture from the same website. We have somebody who's shaking here, sweating a lot, feeling very anxious, dizzy, hungry, is having a very fast heartbeat the way mine is right now, has having impaired vision, is feeling weak and fatigued, and they're having a headache and tend to be very irritable. Like it's lunchtime and I've not had my food and I want to beat up that person who's trying to talk to me on the phone. What do we think could be happening? Can you have the question?
Okay, good. So I think we can't be able to tap onto we'll just do a show of hands.
So I think we'll just show of hands. So my question will be, what is or are the most likely diagnosis for this person who's shaking, sweating, feeling hungry?
Okay, it's working now, eh?
I think we've got the answer there.
Okay, we're back online. So
100%.
Yes.
Very good.
So we're back online. Excellent.
So all that we've been taught in the last few days is all here now. Next slide. Next, please. So just a small thing. You have this person who keeps coming with hypoglycemia or symptoms that fit hypoglycemia. What is it that you need to understand? You must understand whether this hypoglycemia is occurring mostly in the fasting state or it's coming postprandial. Why is this important? It actually gives you a bit of a hint on what could be the possible causes. If you have the Whipple's triad, which is somebody who has symptoms of hypoglycemia which are relieved by taking or raising the blood sugar by whatever means, if they have lab or bedside evidence of low blood sugar, and if this hypoglycemia is mostly in the fasting state, you must think about a possibility of excessive insulin secretion, especially an insulinoma. If somebody is having a reactive hypoglycemia, they are not diabetic. There is no history of pre-diabetes in this patient, but they do have like the symptoms 2-3 hours post their lunch or dinner. What do we need to look for? We must rule out insulin resistance, we must rule out pre-diabetes, and we must rule out especially type 2 diabetes. So it's not that somebody is having hypoglycemic episodes, they cannot be diabetic. They can, even if they are not on treatment. Next slide. So we have this 14-year-old boy who comes after using topical steroids because he's been having eczema for the last 5-10 years, and this is what he comes with to your clinic. Most of the times these patients will come wearing very long-sleeved shirts or t-shirts or sweaters, and we don't even look at them. They'll just say, I'm gaining a lot of weight. If we don't examine these patients fully, we will never be able to pick some of these signs. Can you have the question here? So what are the 2 routes of steroid administration that are most likely to cause this kind of presentation in your patients? I think the history for this patient is misleading a lot of us. Okay, so most of us think that it's topical and systemic, while a few of us think inhalation and systemic. Nobody thinks it can be topical and inhalation. The answer actually is inhalation and systemic. A lot of studies have now shown that inhalational steroids are more related to Cushing syndrome and are also some of the causes of adrenal insufficiency. So you may not have Cushing's, but they tend to get adrenal insufficiency, inhalational steroids especially, and of course our systemic steroids. Next. So this is again a young woman, comes with frontal headaches lasting for the past few months on and off, and she's having unexplained weight gain, and she tends to knock herself every time she tries to walk next to a wall. Question? So what do you think is the first line treatment for this condition? The radiograph there is a hint to what could be the cause of this lady's symptoms. Once you get the diagnosis, then you're able to tell what exactly needs to be done for this lady. Sometimes these conditions sound like they are far from us, but they are just in front of you. It's just that we don't really link up everything and think about it as such. We'll send them to the ophthalmologist, not even the ophthalmologist. They most of the time end up with the optician who will give them glasses, and the patient still keeps continuing with the symptoms. After one doctor is not able to help, they tend to go to the next, and nobody is able to link up until sometimes it's too late. Okay, so most of us think that she needs to have weight loss. Is there anyone who can help us with what the diagnosis could be? Let's start from there. Anybody who can tell us what's the possible diagnosis for this lady? Yes, not an endocrinologist, not Dr. Irene and Dr. Rosie. Can we have somebody from the back giving us the diagnosis? Hint, it's in the brain. Hint, she has Cushing's syndrome. I don't know if I need to give any more hints.
Yes, any brave person?
Okay.
Yes, Dr. Nancy Mora.
Pituitary adenoma.
Very good. What kind of pituitary adenoma would give you this? So an ACTH producing pituitary tumor is a most likely diagnosis, and the treatment of choice for ACTH producing tumors is usually surgery. Of course, weight loss and the rest comes, but the treatment of choice is surgery. Next. So not every obese, overweight patient needs exercise and diet and Ozempic to lose weight. Some of them need much more than what we are seeing. So this is just in a nutshell what somebody with Cushing's syndrome or Cushing's disease will come with. They'll have anxiety, depression, they may have memory issues, attention problems, they do come with brain fogs, which a lot of times we have. A moon face, oily skin, acne, they may have flushing of the face, hirsutism or irregular hair growth, they'll have problems with their menses, they may have unusual weight gain, especially above the collarbones, and the typical Cushing's presentation, high blood pressure. Do we usually look at high blood pressure and obesity and say what could be going on? Do we examine their abdomens to see if there are any stretch marks, their arms, their axillary areas, to see if the blood pressure is linked to the weight or not? We always look for weight and diabetes, but we often miss the weight and high blood pressure. Next. This is a very interesting picture. I don't know if everyone can see this. You have this gentleman in the first three pictures, A, B, C, when he's unwell, and D is his photo a few months before he presented to the hospital in a sick state. Can you have the question? Okay. So which of the following lab findings are consistent with this patient's diagnosis? A little catch here. I didn't want to put it very straightforward, otherwise I think everyone will get the answer. A morning cortisol level more than 10 micrograms per deciliter, early morning serum ACTH level of 138 picograms per milliliters, partial pressure of oxygen of 58 mm mercury, and HB of 8 grams per deciliter, all of the above, none of the above. A hint, compared to his previous color, this patient's skin color has changed to a darker tone. Very good. I can see we have very smart people. So, okay, almost there. Very good. So the answer is early morning serum ACTH level of 138, which is over more than double the normal as per most lab references. This patient has adrenal insufficiency, to be precise, Addison's disease, which is causing the hyperpigmentation. So the hyperpigmentation is usually found in patients who have primary adrenal insufficiency. Somebody with low ACTH levels will not get hyperpigmentation because ACTH can act as your melanotropin releasing hormone and cause that. Can you have the next? Again, in relation to the first, we have this old lady comes with low blood sugars, low blood pressure, especially when she bends down, she feels very dizzy. She's been having diarrhea and losing a lot of weight, and she feels very weak, especially in the evenings. She cannot even cook for herself. She just wants to sleep. And there are some changes in her body hair distribution. So what do we think is happening to this lady? Next, the question. So what is the preferred medication for this lady, starting from the least to the most preferred? Hydrocortisone as the least preferred, and dexamethasone as the most preferred, prednisone as the most preferred, dexamethasone as the most preferred, and none of the above. Maybe I should have also asked why you prefer that over another. So as we answer, somebody can tell us why they would prefer their preferred choice compared to the least preferred. Anybody? Dr. Irene.
So in a patient with adrenal insufficiency, the most preferred steroid is hydrocortisone. That's because also it has a slightly shorter duration of action, less glucocorticoid side effects. The least preferred, and also it's preferred because it also has mineral corticoid activity. Dexamethasone is does not, yes, it's a glucocorticoid, but it doesn't have as much mineral corticoid activity. So it's the least preferred and actually not recommended for adrenal insufficiency.
Very true. Most patients with adrenal insufficiency have mineralocorticoid deficiency, which actually is the reason why they get most of the muscle weakness and all, because of their hyponatremia, hypercalcemia, hyperkalemia. So thank you for that. Next. We see these are just simple things. We all see hyponatremias, hyperkalemias, but do we think about adrenal issues? We see patients with renal insufficiency being managed for hyperkalemia. We keep shifting that potassium for hypercalcemia. We keep looking for that PTH and vitamin D excess, and we can't find anything. We must think about this. it's not always sepsis that causes hypotension and electrolyte disturbances. In fact, AI is much more prevalent than we think, especially in our ICU and HDU settings. If you could just be screening all those hypotensive patients with electrolyte disturbances, you would find that it's much more common than we think, especially because of herbal medication use, which is rising each day. So this is just a summary of what you might find in a patient with adrenal insufficiency. In addition to what we have already seen, it just puts everything together, and you can see anemia. Some patients do have lymphocytosis, eosinophilia, especially when you have autoimmune adrenalitis, which is one of the most common causes of Addison's disease, in addition to TB in our setup. Next. So apart from the common causes of AI, especially the most common being exogenous use of steroids and sudden withdrawal of steroids, we do have these rare disorders such as the adrenal leukodystrophy syndrome. I just thought of putting this here because I have had an encounter with a patient who was a 25-year-old male who came with ambiguous external genitalia and was done surgery because he wanted to be a male, and he also used to have this hypotension, especially postural hypotension. He did have easy bruising and he was losing weight, but nobody understood what was causing this weight loss. He used to have nausea, vomiting, so he kept seeing the gastroenterologist. And one of the causes of this could be adrenal leukodystrophy, which is basically excessive accumulation of those free fatty acid chains around the neurons, and it causes neuronal destruction. But it can also affect your adrenal glands, and you tend to have adrenal insufficiency. There are various types. Most commonly occurs in childhood and they barely make it to adulthood, but there are the less prevalent ones which tend to grow up to adulthood and present with adrenal insufficiency without any neurological symptom. But if you find a patient who's having adrenal insufficiency and has been having problems with growth, especially if they have mental issues, then you must look for possibility of adrenal leukodystrophy. Next. So this is comparing Addison's disease, Cushing's syndrome. You can see somebody with Cushing's tends to be bigger, tend to have a lot of stria. Somebody with Addison's disease is much smaller, will have hyperpigmentation in most but not all cases. They'll have cardiac insufficiency, of course hypotension we've seen, and the common causes being autoimmune, adrenalitis. We also have infections, especially TB, but there can be other infections as well, and metastases. We have had patients who came with pulmonary nodules. Actually, he came because he had this chronic cough and was being treated for pneumonia. CT scan showed pulmonary nodules, and somehow when they were doing the CT chest, they picked something in the adrenals. When we screened, we did an adrenal protocol CT scan, he actually had adrenal masses. So we should think about metastasis as well. Next. Nice one. So we have this middle-aged man with few years of intermittent hot flushes, palpitations, and gets hypertension. I think we already know the diagnosis, but just for those who don't know, what do you think those skin lesions are? So that's neurofibromas, and we saw some dark patches, café spots. We usually feel that in our dark skin we can't see, but if you look carefully, you'll always find café spots are very common. You don't always have to have a disease state to have them. Some people just have them without really being sick or having any of these fancy syndromes. So most of us thought it's a pheochromocytoma or a neuroendocrine tumor. We are all right, because pheochromocytomas are also a type of neuroendocrine tumors. And not to forget, there is also paragangliomas, which are just pheochromocytomas, but outside the adrenal glands. So if it's not always that you suspect a pheochromocytoma, you've done your urine or plasma metanephrines, they're elevated, but the adrenal gland looks clean. We must look for the source of those in and around our. Okay, so that was just a bit of fun there. We have the Hulk, he's trying to run away, he's looking scared, and he was also looking like he has a lot of energy, and that's what you find patients with pheochromocytoma may present with, because they're having excessive epinephrine, norepinephrine. They have a lot of variety of symptoms, signs in pheochromocytomas, and they tend to be usually overlooked. A lot of times these patients are checked for thyroid disease. We keep looking for hyperthyroidism, even if it's not there, but we still feel like maybe we've missed something. We label them as having panic attacks, anxiety disorders. They go to see the psychiatrist. It takes years before they tend to be diagnosed. Next. So I have this patient, maybe there is a question there. We had already answered this. There is a next question. Number 9. Okay. Next slide. I think we've already talked about hyperthyroidism. Dr. Sarah had already projected, so I'll not go back to that. But just to say, you have these thyrotoxic symptoms that have been for a few days, few weeks. Please do not rush to treat them with carbimazole, methimazole, propylthiouracil, especially if they're having an anterior thyroid swelling which is painful or tender. I often see patients who are sent from various disciplines, including the ND, who have been having this very tender anterior neck swelling. They've done ultrasound, which is showing a thyroiditis. Thyroid function tests are showing overt hyperthyroidism, and they've been put on carbimazole. It could be subacute thyroiditis, acute thyroiditis, and the danger of putting them on antithyroid medications is that you risk pushing them to long-term or permanent hypothyroidism. So you must be sure before we start antithyroid medications for these patients. Next. There's a question here, I think number 10. I think most of us have already seen and decided what the diagnosis is. No, I think this, the question is, let's do number 11. Okay. What is the most likely diagnosis? Thyroid eye disease, or we got it. What was the hint here? Because all these conditions can give you proptosis exophthalmos. Exactly. So the thyroid swelling. You'll see many people with thyroid anterior neck masses will cover their neck. They'll wear a scarf, they will put on t-shirts that will hide it if you do not examine them. And a lot of times the proptosis is on both sides, so you'll easily miss it because it may look like it's just their normal eyes, because a lot of people have normal eyes, especially those who wear thick glasses. They've had this myopia for many years. They can have bulging eyes, so you have to be careful. Not everyone has Graves' disease or thyroid eye disease. Next. There's a question there, number 10. So I have this patient with poor memory, having problems concentrating at work, are not able to hear well, their voice is changing, it's becoming more hoarse. The extremities are cold. I think there are 2 or 3. So this patient has very low levels of thyroid hormones. Their cortisol levels are also very low, and they have no access to an SDTH stimulation test. What would you start first? Adrenaline, noradrenaline, steroid, levothyroxine, steroid, levothyroxine, levothyroxine, steroid, start both together. All are correct. So most of us got it. You have to start the steroid first. This patient is having adrenal insufficiency in addition to hypothyroidism. Imagine what happens when you give levothyroxine. Your metabolic rate will go up and you will start having hypotension. You'll start having hypoglycemia. You go into an adrenal crisis if you are not careful. So always start the steroid before starting thyroxine. There is no rush in starting thyroxine in such a patient. You can always wait a day before you give them stabilize. Next. Those who like WWE might have seen this wrestler. He's very famous. There's a question there. Anybody knows what his height is? So what is the most likely clinical condition in this patient? Is it gigantism? Is it acromegaly? Is it both? Is it Paget's disease? Is it all of the above? I can see most of us are getting it. So gigantism just means being very tall. Acromegaly is somebody who's having expansion in the horizontal. So you have wide fingers, you have a protruding lower face or chin. And so this guy is Kali. He's a very famous wrestler, also known to have gigantism and acromegaly. He had a pituitary adenoma, which he had resected in 2012. But unfortunately, some of the features never reversed. Next. Just to emphasize on what you find in acromegaly, you have a prominent forehead, enlarged nose, enlarged lips and tongue, and a prominent chin and jaw. We must be careful because not everyone with these features has acromegaly or excess growth hormone. There are other reasons. Somebody with Paget's disease can also have these features, and it's important to know whether this has been there from the time they are born or it has come as they started growing older. Next. So why do we worry about acromegaly, especially growth hormone excess? It's just about the looks. It also because it's associated with increased cardiovascular morbidity and mortality. There is increased risk of precancerous colonic polyps, and there is risk of colonic cancer. So we must be on the lookout for such patients and screen for colonic polyps. We all do all those brain MRIs and CT scans, but we forget that there is also risk of malignancies. Next. think not much. So we have this patient who's having infertility, galactoria, and libido, and there's a question there. Almost. What goes in your mind when you see someone with galactoria? It's a female. So what is the blood test that you would want to do in this 25-year-old lady? And she's not on any medication and has not recently been on any medication to give her these symptoms. She's not lactating, she's not pregnant because she's having infertility. Good. So these are symptoms most likely because of hyperprolactinemia. Of course, we need to find out what the reason is. It's not always a prolactinoma, but it's important to start with the serum prolactin level even as you look for your other hormones, the TSH and the likes. Next slide. So just wanted to highlight this because a lot of times we get called by doctors saying, I have a patient, doc, in A&D having polyuria, polydipsia. I've done the blood sugars, I've done the HbA1c, and they are all okay. What should I do? But she's having a lot of polyuria and keeps drinking water the whole day, keeps having a dry mouth. So we must remember hypercalcemia for whatever reason. We should remember diabetes insipidus also, although very rare, especially if somebody is not undergone any cranial surgery. DI is a rare disease, but it's still possible. And of course, a few people may have psychogenic polydipsia. So it's not all blood sugars. Next. It's a question there. So I have a patient having joint pains, bone pains, depressed, having trouble with concentrating, loss of appetite, feeling nauseated, confused, vomiting. What are the likely complications for this patient? Ketoacidosis, hypotension, coma, cardiac arrhythmias and AKI, acute pancreatitis, hypotension, coma, 1, 2, 2, 3. The hint lies in my previous slide where I said all polyuria, polydipsia are not hyperglycemia. Of course, this patient can get any of these, but we are talking of what are the most likely. This is a patient who's having hypercalcemia.
Okay. So
Sorry.
I'll just interrupt you slightly.
No problem.
Yeah, so Professor Kunya has to catch her flight. She needs to leave at 1 sharp. So I think, no, just there. So I think let's just have her officially, since she has to leave in a few minutes, maybe just close the conference and give us a few words. And then from there, we can continue. Yeah, thank you.
Okay, good afternoon, everybody. It's been such an exciting few days, don't you think so? I think we've had excellent presentations, a good program. I think it was very heavy in terms of we've had long days, but we've had people staying on into the evening. So on behalf of the Kenya Diabetes Study Group, I just want to thank each of you for taking your time to be here, to spend our weekends with us, our international delegates. I can see some of them are still in the audience and haven't taken their flights out. And all our local and international faculty and delegates, thank you very, very much for contributing to a successful 9th conference. I want to thank our sponsors also, and we'll have a formal thank you for each of you. And thank you for supporting us. We look forward to seeing you at the 10th Annual Conference. And I just wish you all a very safe trip back to your families and continue to change diabetes and endocrinology in this country and in the region and beyond. Thank you.
So thank you for that. I think you can just wrap up, then from there I can close officially. Thanks.
I'm almost done. So what I was just highlighting in this slide and question is that this patient most likely has hypercalcemia, and hypercalcemia is not as benign as we may feel. It does cause all those complications that we've seen, especially kidney injury with recurrent kidney stones. You can have nephrocalcinosis, you can have cardiac arrhythmias, so we must treat it with the urgency that it needs. Next. So just to mention, there is hyperparathyroidism with hypocalcemia, but we should also remember that there is hypoparathyroidism with hypocalcemia, and not all low calciums are low vitamin D. So even as we do our vitamin D levels, even as we think about malabsorption, we must think also about hypoparathyroidism. And the catch is that when you do a PTH level, always do it with a calcium, phosphate, and a vitamin D. Alone doing PTH levels does not help us. Next. So even for the nephrologists, when they do a PTH alone, it doesn't help us in managing the patient. So this is a very interesting one. We just hold on the question. We have this 35-year-old female with right adrenal incidentaloma on a CT MRI, and showed left adrenal hypertrophy, also short for age, and having breast underdevelopment with hirsutism. Part B is a male, 52-year-old. He's having short stretcher, and he's a father of 1 year old, one boy. He's having abdominal obesity and has been on treatment for diabetes, hypertension. He's also had treatment for metabolic acidosis coming with hypovolemic shock, and his ultrasound CT scan showed enlarged adrenals. We have the last one being a 12-year-old female, comes with virilization. Somebody would easily mistake them for a male. So there is a question there. So what is the most likely diagnosis for all three patients here? I want a common diagnosis for all three of them, although all the answers could be correct, but there is one that fits all of them, and that is congenital adrenal hyperplasia. They do have disorders of sexual development, but they also have adrenal insufficiency, and if we don't treat them appropriately, they may come in an adrenal crisis. Sometimes they come with very mild signs and symptoms which are easily missed, so we need to look at that. Next. So mainly just to summarize, congenital adrenal hyperplasia, as I'd said, they do have disorders of sexual development, but they also have adrenal insufficiency, and they can have issues with growth delay and osteoporosis. Next. So just to highlight, there are several types of adrenal hyperplasias depending on the enzymes that are involved. The most common being the 21-hydroxylase deficiency, but you can also have problems with 17-alpha-hydroxylase and 11-beta-hydroxylase. And what happens is that because they are not able to channel their cholesterol to give you cortisol and aldosterone, they tend to produce excessive amounts of androgens, and that is why they have these ambiguous genitalia and sexual disorders. Next. So it just highlights the different types of congenital adrenal hyperplasia syndromes. And there are those who have salt wasting, and there are those who will not have salt wasting. So those who have salt wasting will need mineralocorticoid replacement. So I have this young lady comes with acne, hirsutism. Next. And she's also having problems with conceiving, infertility, mood changes. So remember, all acne and hirsutism is not just because of puberty, and also it's not all because of PCOS, which is what this girl is having. Next. And we must address all parts of this patient, not just the infertility or just the acne. You look at the patient as a whole. We've had a lot of presentations on PCOS. I'll not go to the polls now, but just to save time, this is a lady with short stature, broad chest, curvature of the spine, having a bit of scoliosis, has 5-spaced nipples, and is having pubertal failure. I think the pediatricians had shown us some of the syndromes, and this is somebody who's having Turner syndrome. If it's a mild form, they may not present until late in life, where they come with infertility. So you have to examine, look at their height and all that, and decide if you need to do karyotyping. Next. Again, just to remind that Turner syndrome is not as rare. About 1 in every 2,000 babies are born with Turner syndrome, girls I mean. Most of them do not make it to adulthood, but there are a number who make it to adulthood, and we need to address that. Next. So this is just like an opposite of Turner syndrome kind of in males. Again, not very rare, and most of them do make it to adulthood. The main issues are reduced fertility, so we need to also address this. They do have hypogonadism, but they also have issues like gynecomastia, and we had presentations in the morning addressing that, so we must look at that and maybe do a karyotyping. Next. I think just in passing, I'll mention that we have looked at the clinical syndromes, but each of these syndromes can also come as a group of syndrome. We have something called the autoimmune polyglandular syndromes. We have 3 major types, and if somebody, especially if a young person is coming with Addison's disease or is having autoimmune thyroid disease, type 1 diabetes, please look for one of these syndromes, because you might miss Addison's disease and the patient can come in adrenal crisis. Next. Again, apart from the 3 main, we have others. We have POEM syndrome. There are those patients who keep coming with hypoglycemia. They might be having insulin autoantibodies, so that when they eat, their sugars are a bit high. But after some time, when the antibodies detach from the insulin, they start getting hypoglycemia. So those reactive hypoglycemia, some of them may be having the antibodies. Next. And then not to forget our men's syndrome. A young patient comes with pheochromocytoma. You must look for a parathyroid adenoma and the likes. If you have a patient who is coming with a medullary thyroid carcinoma, please don't forget to look for pheochromocytoma. They tend to have similar symptoms, and we easily forget, and sometimes after treatment we are wondering why they are still not improving in terms of their symptoms. Next. I think I'm almost done. And then of course these rare things called von Hippel-Lindau syndrome, not so rare. We must think about this, especially if somebody is having retinal hemangiomas, very common, and you can have pancreatic cysts. They may present with diabetes. They can come with pheochromocytomas. They may have issues with infertility, especially in the male. Next. I think that's the end of my presentation. Thank you. Anybody has a question or a comment? Anybody who wants lunch? Yes.
So another big round of applause. Thank you so much, Dr. Dara, for those excellent cases. So I think now we've come to the end of the conference, and I just want to give now a vote of thanks. It's been amazing, 4 days, and I want to thank all the delegates who've come all the way from Wednesday up to Saturday today, and even our sponsors. There are quite a number of sponsors, and I may not be able to read all of them, but I'll just name a few companies in terms of those who've been able to make it a success. So Boehringer Ingelheim, AstraZeneca, Beximco, Tiba Healthcare, Novo Nordisk, Q Pharma, Square Pharma, Sun Pharma, Troika, Viatris, Zamara, and also Life Care. We have GoodMed, we have Glenmark, we have Getz, we have Galaxy, Eva Pharma, Dawa Life Sciences, Cosmos, Cipla, Contour Plus, Lancet, Chem Labs Limited, Brookside, Biodeal Life Sciences, Bibron, Adjanta Pharma, Allmed, Aga Khan Hospital, Group Ethica, Sanofi, Harleys, Inosia, who gave us the excellent bags that we have for this particular conference, Metropolis Labs, Microlabs, Novasi, Novartis, Philips Therapeutic, Radiance, Savia, and CC Pharmaceuticals. So those are the main sponsors who are able to make this conference possible through their sponsorship. Microlabs and Cosmos specifically, they sponsored quite a number of doctors for this particular conference. So we are truly grateful, as well as Glenmark, and Novartis, AstraZeneca, Inosia, who also sponsored quite a number of doctors for the conference. So let's give them a big round of applause for our pharma. I just want to mention some key vendors who also played a very key role. We had Basek Limited by Bonnie, who did our excellent booths outside. Round of applause. Daktari Online doing all our audio-visual, daily YouTube links, and all these videos will be uploaded onto our KDSG website and platform. We have CMOS, who've done our lovely programs as well as our banners and everything else. We have TechBiz, who've been doing the QR codes and the IT support for this particular conference. The excellent screens from Chromatic Media, the lovely decor yesterday at the Gala Dinner from Glam Decor. Silverhearts, who've done all the ticketing for all the executive, faculty, and a number of the delegates. So who are the main vendors who did a very key role. So let's give them a big round of applause. I want to thank Ministry of Health for helping us launch our guidelines officially, and we're going to move forward with them in terms of nationwide guideline dissemination. Dr. Gladwell Gadesha, Dr. Elizabeth Onyango, and Dr. Dominic Ongaki, and Dr. Isaac Bashir, and also we had Dr. Steven Motiso, who also came for this particular conference. So big round of applause for the ministry, and we look forward to further collaborations. The executive committee, led by Professor Kunyiha and our Vice President, Dr. Rosalind Gugi, our Secretary, Dr. Nicola. We also have the other members, Dr. Irene Jerry, Dr. Wairagu, Dr. Florence Kelly, Dr. Saira, Dr. Mohamed Gaman, Af Kalsi, Fabian Collis, Beth, Dr. Jacqueline, Dr. Betty O'Kerry is our nutritionist in the group, Dr. Nyawera, and also Dr. Paul Ngugi. So thank you so much, and also Dr. Davis Ombui, who was not able to make this conference. He lost his dad, so please let's keep him in our prayers during this difficult time. I also want to thank the ushers from Moi University, who are also part of our team during the CAP conference in Eldoret. So they've really helped us a lot during the entire 5 days for the conference. So Moi University students, thank you so much. Let's give a big clap to them. Our international faculty who've traveled from various countries, including Rwanda, Botswana, and Ethiopia. Dr. Julia Molefe, Dr. Polos Ephraim, Dr. Rediet Ambachu, Dr. Devota Mukeshimana, Dr. Marie Morai Katete, difficult name. So thank you so much for our international faculty, as well as the farmer who made it possible for them to travel all the way to Mombasa. So we are truly, truly grateful. So I think now that brings us to the end. Just a few announcements. The next major event in the diabetes calendar will now be the DMI walk. That's the Diabetes Management Information Center walk, which will be held surprisingly on my birthday on the 6th of July. That will be at Carnival Grounds. So please, this is a very, very important work because this is what actually funds the free insulin project in our country. So we are very privileged to have the CDIC program, which has actually been led, and I want to thank our colleagues in the pediatric space. They were here and they gave us an excellent series of talks in the pediatric endocrinology space. We thank Novo Nordisk, Ministry of Health, who've been able to make this particular project viable and sustained all through the years. So please, there are charts outside there, and exactly how you can register for the walk. There's a lady just outside these particular exits, and also you can talk to ZP or Carol. So buy a chart, please support a child living with diabetes. Let's all come out there in big numbers and let's walk. Encourage your children. There are a lot of schools which take part in this particular walk. So please, let's do what we can in terms of trying to support this very noble initiative. So let's all meet together in those colorful, nice blue shirts, and let's work for these children to try and make this project sustainable and a success, and to give children a future who may be living with type 1, or who are living with type 1 diabetes. So apart from that, just a few announcements. There's someone I think who lost their ID. So I think if anyone comes across an ID somewhere, please forward it to either ZP or Carol or myself or Roslyn. I think that's all in terms of now. We'll have